So next patient is liver anatomy and surgery. A 60-year-old gentleman with a history of hepatitis B infection has had a routine surveillance abdominal ultrasound scan, which shows a 4 centimeter hypercoagulation in the right liver. His liver function test is normal. What is your concern? My concern is hepatocellular carcinoma. I am aware that 10 to 15% of the patient also develop cholangiocarcinoma. How would you confirm your suspicion? I would do a triple phase CT scan or MRI scan to evaluate the arterial enhancement of the portal and venous delayed washout of the lesion to establish my diagnosis of HCC. What additional information will the scan provide? So imaging not only establish a diagnosis but also provide other information like cirrhosis, extent of the disease like number and size of the lesions, and abdominal staging, lymph node, adrenal bone mets, and assists the operating planning. How does imaging assist in operative planning? Imaging helps to delineate the segmental hepatic anatomy and assist in surgical planning. It provides an estimate of future liver remnant, which is an important determinant of resectability. What is FLR and its implications? The volume of the liver is calculated by a computer based software, and it's called future liver remnant. In a healthy person can have minimum of FLR 20 to 25%. The patient with previous chemotherapy exposure needs FLR of 30 to 35%, and a cirrhotic patient needs an FLR of 40 to 45%. This is due to the reducing regenerative capability of the liver in cirrhosis. FLR can be calculated from the CT. How can we accurately estimate the liver function test? So crudely, we can do the routine blood test like bilirubin, ALT, INR, albumin, and then liver function test and portal hypertension, platelets, and hemoglobin, and renal function test, creatinine. But these are the important parts of the child scoring system, and patients with child score C are not candidate for surgery. The indocyanine green test can obtain a more accurate estimate. What is indocyanine green dye? So indocyanine green dye is injected in the liver. It's metabolized by the liver, and in 15 to 20 minutes, all cleared from the circulation. If someone has more than 15% indocyanine green after 15 minutes, is considered a contraindication for major hepatic section. If we do at that in that patient, they will end up having a liver decompression, and failure is imminent with increased 30 to 90-day mortality. She is child score A and is determined suitable for surgery. What are the principles of liver resection? The liver is made up of the 8 conod segments, and principles of hepatic resection dictate that a minimum of 2 contiguous segments must be spared with intact portal, venous, arterial, and biliary drainage. What are the complications of hepatic resection? Bleeding, bile leak, liver dysfunction, liver failure, abdominal sepsis, and death. Suppose this patient is not fit for surgery. What are your options? Hepatic resection or transplantation is the only curative modalities for HCC larger than 3 cm in size. Radiofrequency ablation is curative modality for HCC up to 3 cm in size. Our patient has 4 cm HCC and she fulfilled the Milan criteria for transplantation, and hence technically a liver transplant is an option. However, since she is not fit for surgery, a multidisciplinary team discussion is warranted with regard to discussing the palliative options like arterial chemoembolization, TACE, or radioembolization, CERT. TACE confers survival benefit to HCC patients. Thank you.